slide, please. Please be seated.
Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goeie. I am the pro-rector of this academic ceremony and chair of the degree committee. First of all, I welcome Mrs. Berta Ganizada. She will defend in public her academic thesis, A Systems Approach to Aortic Wall Pathology, Bridging Fundamental Research and Clinical Practice. Welcome all members of this degree committee, and I would like to welcome in particular 4 supervisors, of which 3 are present. Dr. Elham Bidar, he is Associate Professor of Cardiothoracic Surgery. Professor Leon Schurgers, he is Professor of Biochemistry of Vascular Calcification at Maastricht University. Professor Maase can unfortunately not be able to be here today. And Dr. Koen Reesink, he is Associate Professor of Vascular Medicine, Biomedicine at Maastricht University. I will introduce the 6 opponents later to you, because if I mention those names all, you will certainly forget, so I'll do that later during the opposition. Welcome to you here in the aula, and I welcome also all followers of the live stream. Mrs. Ganizada, may I invite you to give a summary of your thesis? Yeah. And I wish you success in the coming hour. The floor is yours.
Thank you, Pro-Rector. So, dear committee of the Defense, Supervision Team, family, friends, and colleagues, thank you for all being here today. In the next 15 minutes, I'll give a short summary of my thesis, which is about aortic wall pathology. So, let's ask the first question. What is actually an aorta? Aorta is a tube that supplies oxygen-rich blood from the heart towards the rest of the organs. And here on the video, you can also see how this looks like in the patient. My research is mainly focused on the ascending part of the aorta. Now, let's look at the cross-sectional view. Here we can find 3 main layers. Intima, which is the inner layer of the aorta, media, the middle layer, and adventitia, which is the outer layer. So, and my research was mainly focused on the media layer. So let's zoom in here. We can find here building blocks, such as elastin, which is responsible for the elasticity, collagen that gives strength, and vascular smooth muscle cells. They help it to contract. So now, when there is a disbalance between the cells and the matrix, which consists of collagen and elastin, the vessel wall or the artery wall starts to adapt to the new environment. And it does it by changing its structure. We call this vascular remodeling. Let's look now at the 3 conditions of the aorta. The first image shows a healthy aorta without any structural differences. The second one shows a clear dilation of the ascending parts. This is called an aneurysm. The diameter can grow above 5.5 centimeters. The last condition is a typically emergency case where you can see a clear rupture or a tear in the aortic wall. And for this emergency condition, unfortunately, we do not have a good prediction. So therefore, we have to look for better markers. Here I would like to show you for each condition that I presented how the aorta looks like during the surgery to give you an impression. As you can see, there is a huge difference in the diameter between the aneurysm and the normal aorta. As well, here you can see how the wall is ruptured in the type A dissection. What you also can see here is that there is a formation of the hematoma, which can lead to fatal bleeding. In 2024, we published a paper where we discussed pathophysiology of the aneurysm disease. Here we also summarized the risk factors, and I would like to highlight now the most important ones. So we know that male above 65 years old, they have an increased risk for aneurysm formation, but also male who have systemic hypertension. What we also know is that there is a high risk when you have a bicuspid aortic valve. And 20% of the aneurysm patients, they have a genetic link with disorders, like genetic disorders as Marfan or Lewis-Dietz. But unfortunately, these clinical risk factors cannot tell us when type A dissection may occur. The current guidelines that clinicians use, especially surgeons, to prevent the risk for type A dissection is to operate all the patients above 5.5 centimeters. But new papers appear, and they show that most of the type A dissection occur at lower diameters, below 5.5. So size is here a paradox, and if we will continue to operate patients above the threshold, we might underestimate a huge number that might dissect at lower diameters. So now you would ask yourself a question: who do we need to operate? Let's look now at the two clinical examples. We have here two patients, Joy and Martin. They have both same clinical history, and also pay attention, they have the same aortic diameter. So the difference here, what you can see, is that Joy has a thicker aortic wall than Martin. So we see then that at the same aortic diameter, we still can find patient-specific clinical differences, such as the thickness, which might be a better predictor than the threshold of the aorta. So we have to investigate this further. And how to do this? In 2023, we published a new approach, which is called systems approach, where we can look and investigate the complex aneurysmal disease from 3 different perspectives. This is from the biomechanical part, so we can look how the blood pressure influences the movement of the aorta by looking at strain data. We can look, for example, at the cell matrix biology by looking at the changes in the cell matrix under different environments. But also, we can include imaging. With the imaging, we will get more information about the flow parameters, but also about the dimension of the aortas. So to realize this, 4 years ago, we implemented a biobank, which is called MAPEX, to study the cell matrix interaction in the aneurysm disease. And my role herein was to look at the differences in the cell matrix in 3 different populations: in the non-dilated aortas, aneurysmal aortas, and in the type A dissection. And in the last part of my thesis, I also investigated the full circumference of an aneurysmal ring to find differences between the segments. So before going to the results, I would like to introduce first the biobank, MAPEX. So this is a platform that we built 4 years ago. And as you can see here, the MAPEX is divided in 3 phases. But what you also can see that we applied here our systems approach. During the preoperative phase, we are collecting data about the wall shear stress and the dimension, which is an important blood flow parameter. During the surgery, we are focusing in 2 lines. First, we are collecting the strain data from the video recordings. This will give us information how blood pressure is affecting the movement of the aorta, but we are also collecting the biomaterials. As you can see here, the ring of the aorta is divided in 4 segments, and each anatomical segment is mapped back using an MRI grid. So this MRI grid is the key player here, which will help us to correlate our data later on with the strain and the MRI data. And in the last part, we are storing the materials, and currently, with the help of the META student team, we will be able to include 300 patients. And now I would like to continue with my results. The first parameter that we investigated was the intima media thickness. Here you can see the aortic wall of 3 populations, the non-dilated aortas, dilated aortas, and the type A dissection. And here clearly you can see that there is an increase in the wall thickness in the aneurysmal patients. But what you also can see that there is a high variation. Let's zoom in here. We can find 2 different subgroups. One group is divided in a thick aortic wall, and the other one is divided in the thin aortic wall. So most likely what's happening here is that the wall of joy that I presented before is undergoing a remodeling by changing its structure to adapt to the new environment. And this adaptation is not present in the case of Martin, which is at higher risk for type A dissection. Then, having this in mind, we also continued and we looked at further building blocks, which are also important, elastin and collagen. What we found for elastin that there is no difference between aneurysmal group and the dissected group. So the content doesn't show any difference. We did not stop here, we went on and we estimated the structural differences by looking at the thickness, for example, of the vessels, but also the space between the vessels. And here we clearly found that there was a decrease in the elastin thickness in the dissected groups, and the same group also showed higher gaps between the lamella. So this means that not the elastin content is affected, but its structure. And what we also see, very interestingly, is that collagen doesn't compensate for this elastin breakdown because there is a decline in these dissected groups. And this keeps the wall weak. In the next part, we also looked into the cells, vascular smooth muscle cells, that are responsible for the contractile function, and also at the enzymes that are produced by these cells under diseased environment. And we found that there is an increase in the cell density in both aneurysm and dissected patient groups, but its contractile function strongly decreased. So this means that the cells, they try to proliferate and compensate for the elastin loss, but they are not contractile anymore. They don't behave in a normal condition. In this phase, the cells, they start to produce enzymes to help the wall to repair. And one of these enzymes are MMPs. And we see indeed there is an increase in the production of those enzymes that may break down further the wall. Now I'd like to summarize the first part of my thesis. Our findings showed that the aortic wall is strictly coordinated by the cell and matrix. And when there is a disbalance, the vascular wall starts to remodel. This remodel can be a positive remodeling or a negative remodeling. Positive remodeling in the patients leads to thickening of the aortic wall, is the case of Joy, and the thinning leads to the case of Martin. And we think here that the thin aortic wall is at high danger for type A dissection. Now, in the last part of my thesis, I also focus on the Fulton conference of the aneurysmal wall. And how did I do that? Here you can see an aortic ring from the patients that were operated for repair. So we have the full ring. And we divided the ring in 4 anatomical segments: ventral, dorsal, lateral, and medial. And if we look at the results, we can see that when we compare the segments at the population mean, we do not see any differences between the segments, which gives us information that aorta wall is uniformly remodeled. However, if we look at the patient-specific level, we see that there are intra-patient variabilities that are very important to track. So this heterogeneity profile might be a good risk factor for type A dissection in the future and could be used in the screening. So now I came to the conclusion of my thesis. I want to conclude here that there is a difference in the remodeling between the aneurysm patient and dissected patients. If you look at the cell-matrix interaction, they do not remodel in the same way. We also saw that there is a process ongoing, such as repair process, that produce enzymes, harmful enzymes, that can further break down the matrix. So if we inhibit those enzymes using a therapeutic drug, for example, we might inhibit also further degradation of the matrix. And as well, our data showed that at the same diameter, we see two different phenotypes. So the aorta doesn't remodel in the same way. And the thickening is at higher risk, and we should investigate those patients from the whole population. So this needs a patient-specific approach. And in the last part of my thesis, I would like to conclude that there are heterogeneities between the full regional areas of an aneurysmal ring, and those heterogeneities might lead to the type A dissection, which we need to investigate further. So now I would like to end my presentation and give the word back to the prorector.
Thank you, Mrs. Ganizada, for a clear summary of your thesis. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Erik Biesse. He is Professor of Experimental Vascular Pathology at Maastricht University. Professor Biesse.
Thank you. Dear candidate, first of all, my congratulations wish you on your dissertation. It's really beautiful work, beautiful cover. Also, the design is good, but most importantly, the content is equally good. You did very important work in standardizing and building this Maastricht cohort, and I think that that's the future PC students and also postdocs and supervisors can benefit from that investment you made. I really admire also your sort of eager and enthusiastic and also persistent spirit in bridging the different partner groups that participated in this cohort. And in retrospect, I need to apologize for these occasions that you popped up at my office with a fresh piece of aorta and said, when can you stay? And I was looking disturbed at these points, but well, I hope you forgive me on that. So I will give you an easy job because I'm the first opponent. My first question relates to proposition 4. And maybe I invite one of your so then you can take a rest again.
Each aneurysm may have its unique path of development, with adaptive and maladaptive responses working in parallel. This thesis.
Thank you. Now, this is a pretty bold statement, and I just saw your conclusions where you say, well, ECM targeting might be a good candidate for future benefit in AI. How do you see that? What are the implications for this proposition 4 statement for therapy design, development?
Yeah.
Is there a pill for all, or what would it be?
Yeah, highly esteemed opponent, thank you for your insightful question. So, indeed, this proposition is about that we see that each aneurysm has a unique way of development. It can have an adaptive or maladaptive remodeling process. And with this proposition, I would like to say that not each aneurysm develops in a same way. So, and we cannot, for example, treat all patients using one same threshold. So we have to look at patient-specific level and identify those who are at risk. And for example, using my data, where we saw that thinning of the aortic wall leads or has more weaker wall tension, for example, which we have still to investigate, we can use those data to apply in the clinic. For example, we can use, before going to the EI, because it's like a far way to go, we have first to understand, is indeed the thin wall less strong than the thick wall? We have to investigate more the composition. For example, at this moment we are thinking about using a tensile stretcher and use the rings to tense them, or isolate the cells from both subgroups.
And this approach will lead you to new targets that might benefit classified categories of patients.
Yes, we have to classify them first. Thanks. And once we classify, they have more information. Sorry.
May I go? So this question was well addressed, but I have another question. In chapter 2, on page 48, the review that you reported, so you have an overview of the current state in the field. And from this, because I'm not an AA expert, from this review I read that aneurysm is much less prevalent in women, but at the same time rupture risk and also mortality is much higher.
Yeah.
So how do you explain this? Is that because women develop this disease at higher age, or are there different things in play?
This is also a very valid question. What we know from our literature study is that women, they have hormones such as estrogen. They are high in the premenstrual pose, so they are higher at a higher level. So there is an age when they become older, this estrogen level declines, which makes it more. So estrogen, let's say, it's a protective factor against aneurysm. And when it declines, patients, they are at higher risk of dissection and aneurysm formation. But there is also known from the literature, once they develop dissection, the outcome is much worse in women. And this has to do with the dimension of the aorta. In women, the aortas are smaller than in men, and the rupture. So the dimension,
the wall thickness. The
mechanism of the rupture and the dimension
that explains a lot. Thank you. If there's time for a brief question with a brief answer. On chapter 4, so I scanned the whole, just to impress you that I read the whole thesis. You, on page 113, you mentioned that CD68 staining of aneurysm tissue, unfortunately, was negative. And that's unfortunate because that's my pet cell that is staining. So can you conclude from this that macrophages are not there? And that they don't play a role at all in the disease pathogenesis?
Indeed, I would like to answer these questions in two small parts. I would be short. So we quantified first the macrophages because we saw an increase in proliferation of our smooth muscle cells in the media. So we wanted to know, indeed, are those smooth muscle cells or are they also macrophage-like cells? Therefore, we stained for this marker. And we didn't find any positive response because our control sample was an arteriosclerotic plaque. So we had a very good control sample. And indeed, our method worked, but there was no positive response. But we cannot say by only measuring macrophages that we can exclude inflammation. We have to add more markers, such as neutrophiles or also T helper cells, to understand if indeed, because macrophages is one part of the inflammation, but there are also other processes that can play a role. So I would, if I would extend this experiment, I would add 2 more markers, neutrophiles and the T helper cells.
Okay, thank you. And indeed, it's a shame that they are not there. So that's... I'll give the word back to the pro-actor.
Thank you, Professor Biese. The next opponent is Professor Ljubica Matic. She is Associate Professor of Molecular Medicine and Surgery at the Karolinska Institute in Sweden. Professor Matic.
Thank you, Prorector. So thank you, first of all, for inviting me to be part of your thesis and to be, it's a great honor to be a guest in Maastricht again with many good collaborators and friends over the years. So I've read your thesis with great attention, almost as a textbook for how to generate a vascular biobank. And that is what we at Karolinska Institute are doing currently, actually, with a new biobank. So it's something that I can take as a ready textbook back to my team at Karolinska and just implement it. So it's amazing work. But apart from that, I want to ask you about some of the propositions that you made and statements that you made. So in the introduction, to start from a conceptual level, in the introduction you mentioned personalized medicine and some ideas for implementing some of your results into patient screening. So how do you think that this patient screening happens? Are there examples, for example, in Europe, where countries have successfully actually implemented the screening for population screening for aneurysms? How hard is it to do that in practice?
Yeah. Highly esteemed opponent, thank you for your compliments, first of all, and for this very good and practical question. How can we identify patients and screen them? So at this hospital, first of all, aneurysm is an asymptomatic disease. It's very hard to see at which point it starts. What we have here in the clinic as a screening is that during the follow-up at the cardiology, sometimes they, with accident, see that there's an aneurysm formation. It's not a good approach because you still will miss patients that do not appear at the follow-ups or do not appear with the cardiac symptoms. So I think this needs a new approach. So why we do not have a new screening? Because we know that patients are asymptomatic. Why do we not do an extra screening during the cardiology consults to see if also the aneurysm is in a good dimensional state? This has not been done yet, and it's not in the guidelines. They don't pay attention only if it's discovered by accident. So this is something that needs to be elaborated further.
Yeah, I guess one of the simple obstacles is the lack of funding in the healthcare.
Lack of funding, lack of, as we say, subsidies.
Yeah.
But what we do have here in the clinic, once the patient has an aneurysm, it's been diagnosed, the patient is referred to the genetic department to screen for all the panels to see. And in this way, we can find if it also appears in the family, once there is a positive response for a mutation. So in this way, but still you will stay in a small circle of the families.
So some form of targeted screening exists.
Yeah.
Good. Dear candidate, one more question. So you have been, as I read from your thesis, very much involved in the generation and building of the MAPEX platform. So a conceptual question again is, do you think that it's important to have research questions defined at the onset of starting a biobank, or can one just start to build a biobank and come up with research questions later?
Yeah. If I would be the PI of a group and I would say, okay, let's build a biobank, I would not start randomly because...
Why not?
Why not? Because you need to have a target always in your research. You need to have, okay, you don't need to have an outcome, but you need to have a line. This is the path that I want to follow. And if you start without any concepts, you will miss also patients. So I would start with exactly what kind of disease I would like to talk with the clinicians, talk with the genetic department and the pathology department, and together collaborate to define the research question from the beginning. I would start it. Yeah.
Thank you very much. So one more question, if there is time. So within your research results, you describe differences in elastin and collagen, and in particular, the decline in collagen is something I would like to address here. So have you looked further than measuring the decline into other forms of remodeling in the tissue and other markers that may actually be upregulated in this situation when collagen of a certain type is declining? But there are other extracellular matrix molecules that may be able to compensate, and which ones? Can you elaborate on that?
So, unfortunately, we only focus now at this moment regarding the time on collagen and elastin, but we were also trying to set up to look into the collagen types. We have collagen type 1 and 3. Using the microscopy, we can identify the type, if it's matured or immature. So to understand why type A dissection, they do not produce the collagen formation. But of course, other important building blocks of the wall could be proteoglycans.
Exactly.
And those ones we should include in our further analysis because they also play an important role in the assembly of the whole matrix. So,
do you know what kind of stainings are used to assess proteoglycan presence?
That's a good question. I haven't elaborated on that yet, but
there's a few different ones.
Yeah.
Thank you very much, dear candidate. I'm satisfied giving the word back.
You have time for another small question, if you like.
Yeah, I have 15 more questions.
But no, if it's not a large one, it's okay.
Yes, but it could be a tricky one, but it's just to discuss. So I'm interested, you mentioned with respect to smooth muscle cell contractile responses, you mentioned that they are dependent on the myogenic cell-cell contact and also neurogenic responses. Mm-hmm. So how about these neurogenic responses? How would they be transmitted onto the smooth muscle cells? Do you think that they have a capacity to respond to the neurogenic stimuli?
Yeah, they do, because neurogenic responses, they're important for the normal maintenance of the smooth muscle cells. So they are the leaders in their contractile function. So if, for example, to answer this question better, we have to look to the mechanotransduction. So we can measure, for example, different pathways that are involved in the cell-cell communication. For example, we can look at notch pathways, if it's impaired, YAP-TAS pathway, but also TGF-beta. And all these pathways together may give us answer about the neurogenic responses in the context of vascular smooth muscle cells.
All right, thank you very much.
Thank you, Professor Matic. The opposition will be continued by Dr. Sam Heuts. He is Associate Professor, Cardiothoracic Surgery at Maastricht University. Dr. Heuts.
Thank you. Dear candidate, I would first would like to start with the compliments for you and your promotion team, and also congratulations to you and your family, and I hope that you have a wonderful day today. As we have seen in your presentation and also throughout your thesis, you emphasize the relevance of aortic disease and the high-risk nature of aortic events, and that they are lethal. And of course, that's as old as mankind, but it has took a while for medicine to acknowledge what an aortic dissection is and that you can die from it, that it can cause sudden cardiac death. So my first question is more historical of nature. Do you know who was the first documented and diagnosed victim of type A aortic dissection?
Really? Probably a surgeon.
That is Michael de Beeky, but that's another interesting story. No, it was King George II of England.
Yeah.
And he reigned England from 1727 to 1760. And on the morning of October 20th, 1760, he went to the bathroom, to the toilet. And when he was there, he developed acute symptoms, and within a few minutes, he passed away. And his physician, Dr. Frank Nichols, he performed the autopsy the same day. And what he describes is a blood-filled pericardial sac with a ruptured ascending aorta and a transverse tear in the intima. And that got me thinking, what does a transverse tear imply? What kind of forces does it imply in your opinion?
Highly esteemed opponent, thank you for this nice introduction and the knowledge that you gave me who developed type A dissection. There are different forces known that can lead to type A dissection. Mainly in our MAPEX, we were mainly mentioning wall shear stress, but of course there are also other kind of forces, such as elongation of the aorta. We know that if there is a 10% higher elongation in a patient, it may lead to type A dissection. But this elongation may also cause a different LVOT angle. Like this is the angle where the blood flows from the heart towards the aorta, and especially the lateral parts. So I think that not only the wall shear stress is here the cause, that we already measuring all the time, but we have to look at broader. We have to look at the whole geometry of the aorta.
I fully agree, because elongation could imply that the tear is transverse. And then when I look at table 1 of chapter 4, I see all these characteristics of 3 patient groups: control patients, aneurysmal patients, and type A dissection patients. And you very nicely described the aortic diameter, because that's the difference between these patients. But I wondered, did you measure the aortic length in these patients? Because I did see that you performed CT scans.
Yeah, unfortunately no, but I know that my research team are busy with this research question. They are measuring now in collaboration with radiology. They are also looking at the length and the LVOT angle.
Okay, because that triggered me a bit.
Yeah.
Because if I understand correctly, it is possible that patients with a normal diameter, let's say the control group, may have an increased pathological length in this study. Is that true?
They might. It might. You mean the control, the non-dilated aortas?
Yes.
But what we know from the literature, when the angle is increased above 60, this gives a risk for the type A dissection. So why would be increased in the normal aortas then?
Well, because everybody, before they have a dissection, they have a non-dissected aorta, which could be similar to the control group, of course.
Yeah, but this could be also a combination of, for example, what we know about our control group. They all have hypertension. So, and this could also lead to an apparent Walschian stress that elongates indeed the aorta. It could be indeed an explanation that once it's elongated, the angle is changing, and then it dissects.
Okay,
with the help of the Walschian stress.
It got me thinking, actually, based on the question about elongation, that there's a paradox within the thesis, and that's particular for this chapter, because you emphasize and you convincingly argue that diameter is an insufficient diagnostic criterion, and it has not sufficient discriminatory power to distinguish patients with a diseased aorta and not.
Yeah.
But yet you are distinguishing the patients based on the diameter. So my question would be, is there a possibility that you dilute the pathological effect of some of the risk factors that you have identified by creating a control group just based on diameter?
Yeah, indeed. So we mainly focus now by dividing our groups on the diameter, and we saw that diameter is not a good marker for the type A dissection. So indeed, we have to look for another new parameter. For example, we can look also at the elongation and LVOT and divide more on the geometrical level the patient groups. That would be more interesting, and especially because now we see 2 subgroups, thinning and thickening of the wall. We can look into how is the geometry different. Do they indeed have longer aortas, or do they have normal length of the aortas? And how is the angle there? And in combination with the Walschian stress, we can picture a new population group.
Yeah, I fully agree. What could be a possibility, and your example of Joe and Martin is very good. What you could do is distinguish based on having the disease or not. So dissection patients or non-dissection patients. And then within the patients without a dissection, you can find predictors by comparing those two with the dissection. Is there still time for a question? No?
Only if it's very, very short, with a short answer.
I was wondering, what is the most promising biomarker, in your opinion, based on chapter 3, that we could use in the clinic? Because we as cardiac surgeons now only use diameter, and if it's 5.5 centimeters, we're almost happy, because then we can operate. But what biomarker would help us best?
Yeah, I would start, because we are a bit far from looking into the wall composition, like collagen and elastin. Our 2-photon endoscopy is not ready yet. So as we know, there's a probe who measures the... But a good biomarker for now, what we can use, is the wall thickness. because there is a photon scanning CT, like still in the research, but we can start there and comparing, indeed, like comparing and also proving my data a bit. Like, is indeed a higher diameter, do all the patients have a thicker wall or thinner wall? This may be a start.
I think your answer is very clear.
Okay.
Thank you very much.
Thank you.
Thank you, Dr. Heuts. The next opponent is Dr. Alexander Gombert. He is Associate Professor of Vascular Surgery at the University Hospital of Aachen University in Aachen. Dr. Gombert.
Thank you for the introduction. Dear candidate, first of all, I would like to say that I read your very decent thesis with great enthusiasm, and your presentation was splendid. And I have been here 2 years ago, and so I know how you feel. So don't be afraid of my questions so far, please. So first of all, I would like to say that if there's one sentence summarizing your thesis so far, is it possible?
To summarize my thesis in one sentence?
One sentence, yeah.
Yeah, it's possible.
Maybe silly, but maybe also easy question.
I will give a try. Maybe it will not
best.
be correctly formed, but I will give a try. Yeah. So I would say that, aorta aneurysm has a unique way of development. And by screening patients under one knife, you would never find high risk or low risk.
Perfect.
This is like
I could say I'm done with my questions, but I need to talk about more 7 minutes. So I would like to underline that this is fabulous because I think treatment in fields of heart surgery and vascular surgery is very decent these days, and we have multiple techniques to treat those aneurysms. But decision making is bad. Yeah, it's really bad, and we have a strong neglect. You talked about biomarkers and all those other parameters, and we focus completely on anatomical findings, and this it's an issue so far. Yeah. So I would like to start my questions as a vascular surgeon. We are talking about these days in fields of vascular surgery of risk modification for our patients. So we would like to prevent aneurysm development, aneurysm growth. And in your first chapter, which is a very decent summary of all aspects of ascending aortic aneurysm and dissection, could you say, I know there are some very underlined risk factors for development of aneurysm in fields if it comes to infrarenal aortic aneurysm and thoracoabdominal aneurysm. But at least in my eyes, there's a slight difference between those aneurysms we treat and those aneurysms which are treated in a LAMS department, for example. Yeah. Can you elaborate this aspect?
Yeah, highly esteemed opponent, thank you for your question. So if I may start first, how could you use one biomarker from, I think you are referring to table 3 of my review, where I summarize different biomarkers. What I saw from my data is under disease environment, the cells, they play a key role in the aorta wall. They start to produce enzymes, they secrete enzymes. Well, for example, we saw that in our aortic wall of the diseased population, like aneurysm and type A dissection, there is an increase of metalloproteinases. So these are harmful enzymes that can break down the matrix. So, but we also saw, which I didn't present today, but it is in my thesis, that there is a decrease in antitrypsin. This is actually an inhibitor of those enzymes. So now we are talking about the mechanical cell matrix interaction pathways. So I would say, why not to find a way to not harm aorta much more to lead to the dissection? Why can we not treat a patient when you see, for example, he has a dilation, there's an increase of growth rate. You can, for example, give him a therapeutic drug that may inhibit MMPs or increase antitrypsin to prevent this proteolytic imbalance between these two groups. So to not to lead to the further degradation of the wall. So if I'm looking at these markers, I would probably start there to first help the patient and see, but for this part that I described until now, you need to do one extra investigation. There are these imaging probes that can measure MMPs in the aorta. So by first scanning the patient using these probes, it's an autofluorescence probe that are still in development, you could identify the level of the MMPs. And those that are increasing with the increasing of the growth rate of the aorta, you can probably use it as a new assessment. So this would be my approach.
Okay, thank you so far. So talking about clinical applicability of all those things you said so far, is it already these days possible to use this for our patients?
It's still in the research phase. Still, they are scanning patients. It started with the mouse models. Now it's maybe used in the first patient treatment, but it's not in the protocol yet. Okay. It's not a clinical routine.
Okay, thank you. So keep it a little more simple, talking about liquid biobanking, biomarkers, all those laboratory findings and stuff. We all look for a troponin of the aorta. It's a holy search, and and I know that in field of cardiac surgery and even in field of vascular surgery, people start talking about BNP as risk predictor for surgery, but not for aneurysm growth. You mentioned on page 15 of your thesis desmosine as a potential biomarker for risk assessment of aneurysm growth and development. Do you have any experience with desmosine as biomarker in the context of your thesis?
Of peptides?
Yeah.
Which page is that?
It's on page number 50, chapter 2. So.
And you may give a short answer, please.
Yeah.
So if not, it's not an issue. You can skip that.
So it's about the desmosine and isodes?
Exactly.
Yeah. So these are two important and good biomarkers because it's the breakdown of elastin, and it's not being used yet also in the clinic. Yeah. It's still, because there was a funny story, but I cannot tell it fully here. We went with my paranymphs to the clinic to look at the blood examination form to see indeed if they are using isodesmosine and desmosine, but no, it's not being used. But they could be a good in combination with an imaging, not solely, because you would never know if the secretion is coming exactly from the aorta. It would be a systemic. It is a systemic biomarker. A blood biomarker you should always
Thank you very
combine.
much. I have to stop you.
Thank you.
Thank you, Professor Gombert. The next opponent is Dr. Jolande Wenzel. She is associate professor at Erasmus University in Rotterdam, and she is head of the biomechanics laboratory at Erasmus Medical Center, also in Rotterdam. Dr. Wenzel.
Thank you very much. Dear candidate, I also read your thesis with great interest, and I'm also very happy that you incorporated more of biomechanical parameters. Normally people collect all kinds of tissues, but they forget about that very important aspect, to my opinion. I really like to discuss with you more of the biomechanical aspects. And then in the review, in chapter 2, at page 30, you start already to allude a little bit on the role of flow. And let me read that sentence. Nevertheless, some longitudinal studies showed that 4D flow MRI can be used as a predictive tool to distinguish low and high voltage stress in aneurysm patients with BAF or without BAF compared to healthy volunteers. And since you mentioned low and high shear stress, what did you really mean with that sentence?
Yeah, highly esteemed opponent, thank you for this careful notification of my thesis. So, first of all, what is wall shear stress? Wall shear stress is the force of the blood that push on the aortic wall. And what we found, a colleague of mine found, is from the radiology and cardiology department, is that there is a higher wall shear stress present in the outer curvature. So our idea came later, why not to combine the tissue of those patients and see indeed if the wall shear stress also affects the wall composition by looking at the breakdown of elastin and collagen. So here with the high and low wall shear stress, we mean that higher force of the blood flow and low force of the blood flow. And what we are really interested in is to look at the full circumference and see if the wall shear stress could be a good marker, because we cannot look into the tissue of all the patients at the moment. Can we use wall shear stress as a predictor?
Okay.
But unfortunately, we were working until now separately. Everyone was doing their own research, and now when we will have high number of patients, we need approximately 200 or more to compare these findings together. And as I was showing in my MAPEX platform, the MRI grid can be the key player here, where we can correlate the exact location of the tissue with the blood wall shear stress.
Okay. And so what is then your hypothesis? Is then indeed the high shear stress being responsible for the aneurysm? Is that what you feel that's happening?
To be honest, I don't think that the wall shear stress is the main cause. In my feeling, how I see the disease, maybe I'm not correct, but I think that the wall shear stress is a consequence. As I explained to Dr. Sam, that there are more factors, such as elongation and the geometry of the aorta, that can change the aorta in that way that the wall shear stress also changes its flow. And there, at this moment, where you see higher flow, so it doesn't start from the wall shear stress. It should start somewhere else.
Okay.
But also, for example, it could also be something genetic. Patients that have thinner aortic wall, they are much more at higher risk when they have a deformed aorta, for example, elongation. So that's why they call aneurysms as a complex disease. There's not one single factor that may lead.
Yes. No, so you mentioned indeed high shear stress might do something to the wall, and that might be indeed a cause of some aneurysm. Now you do also have these days other shear stress parameters like transverse wall shear stress, TSVI. Do you see any kind of meaning for those shear stress parameters in terms of prediction for aneurysm formation?
So you're mentioning the tensile stretcher, or?
No, I really mean the shear stress,
Yeah.
and you do have other shear components, so
Yeah.
you can actually have the shear stress in the flowing direction, but also transverse on
Of course.
on the flowing direction, and they call that transverse wall shear stress.
Yeah.
So do you see a role for that parameter?
Of course. We should, I think, in my opinion, include every blood flow parameter that is present, that is related to the blood flow. And this could also give a better answer about, because the stress is not only longitudinal, it can also be circumferential, expanded.
Yeah.
So we have to look at the both directions, and which we also want to include in our tissue, because now all the tissues are stained and analyzed in longitudinal direction. What about circumferential direction?
Okay.
Because the forces are different.
Yes, then I'd like to go to your MAPEX platform, where you also try to identify all these forces, both the shear stresses, but also the distensibility or even the strains. And you do that by 4 patches on the wall. I was wondering, would it even be possible, because it's only one location, that you actually can really image? Did you consider to actually use the other tissues to do in vitro strain measurements, for instance?
So, yeah, that's a very good question. We were thinking about that with our team, because what we are doing now, we are using the how do you call this, the plates only on the frontal side of the aorta. But the tissue, it's a circle. How about the other part? What about the dorsal part? How we could do that, we cannot do this in the patient. It's difficult. We don't have enough of time during the surgery, and we have already a good privilege to start with the frontal side. But how could we address this question is by taking out the ring, stress it, using the flow chamber, for example, or the tensile stretcher, and look at the different sides, how the wall sensibility is behaving. But in patients, you could use some plugs under the aorta, but it's very difficult to track
But would it not be much more important to know the stresses in the wall itself? Because the stresses make it break, make it rupture.
Yeah.
And that's what you can do with computational modeling.
Computational, yeah, but then you are limited to the frontal side, right? No.
Oh, you can do modeling, right? So you can make 3D reconstructions.
Yeah.
And so I would think that the stresses itself are even more important because you really want to know which part is going to break and which one is not, and which patient is in danger for rupture and which one is not.
Yeah, indeed. Thank you for this recommendation. We will take it into the account.
Okay. I'm satisfied. I give the word back to the prorector.
Thank you, Dr. Wenzel. The sixth and last opponent is Professor Rory Koenen. He is Professor of Vascular Inflammation and Thrombosis at Maastricht University. Professor Koenen.
Thank you, Mr. Prorector. Yeah, dear candidate, also from my behalf, my best felicitations and congratulations to you and your supervisory team. And I've really enjoyed reading the thesis. So first, I would like you to ask you a general question, whether you know the Alcapa syndrome.
Unfortunately, no.
No. Well, my wife actually looked at your cover and she immediately said, oh, this thesis must be about the Alcapa syndrome, because the Alcapa syndrome is a very rare syndrome where the riva, the ramus interventricularis anterior, originates from the pulmonary artery, as it is exactly shown on this picture by the heart here. And also for the vessel that extends to the top of, we have to find a name when we have a drink afterwards. But now to the real thing, of course, and that's the contents of your thesis and not the cover. And I would like you, when I was reading chapter 3, and of course I know your work, I was looking at the differences between the ATAA, so these are the thoracic aneurysm patients that didn't rupture, and the ones that did rupture. And you, of course, took a lot of effort to differentiate between the two. But I was just thinking, what is the difference between these two patient groups? Isn't just that the ATAAD, so the dissection group, is simply the ATAA group, but with bad luck. So is bad luck not the only difference between the two groups? What are your thoughts about it?
Highly esteemed opponents, this is a very interesting question to think about. I do not really believe in bad luck. There should be a reason behind every consequence, right? So what I think is that within our aneurysm group, there are huge differences, as we saw. And not every patient, they have the deformation of the aorta. So as I explained now, there are different factors such as composition of the matrix, but also geometrical factors. So I think that there are patients that dissect at lower diameters. They have just bad luck that their genetics is not good enough, let's say. Yeah, there are different groups, and we have to investigate them further.
Okay, thank you. So, what do you think? Because I was looking at these pictures, and I was thinking, suppose there is no difference or between the groups, or how can you distinguish between before and after differences? Because, of course, such a dissection puts a lot of stress and pressure on your vessel, and you take it out, and maybe it's simply malformed, and you're just looking at supposed differences that are simply the result of the malformation mechanically due to the insult. What are your thoughts about that?
So how can you track them?
Yeah, how can you how can you say this is a true difference?
Yeah.
And this is a difference that just came because we had this massive insult. How would you go about this? If I were the meanest reviewer you could get for your paper.
Well, we have now in our biobank a clear example of a dissection. So we know how it looks like from the histological point of view, but also during the surgery, the surgeons, they see it. So we have some features that we can record. We have to really now not to focus on those that dissected, we have to go back to the aneurysm group. and find there the early features that may lead to this progression.
Great. Before the pedal may come in, what would be your favorite feature you would focus on based on your results?
Yeah, I would choose the most easy one that are already in the investigation and in the research of the aortic disease. I would go with the imaging data using the wall thickness in combination tracking the MMPs. Because if MMPs are high, you would already know that there is a phenotypic switch of the vascular smooth muscle cells.
Great.
So you don't need to go from the beginning of and looking at the, you can look at the collagen elastin, but I think the cause, the consequence, the MMP production, may also tell you a lot about the process.
Thank you. Thank you for mentioning the MMPs, because I had during the whole discussion a question arose about the MMPs. Where do you think these MMPs come from? Because in your thesis, they appear to be just there.
Yeah.
But what is the pathomechanism behind the presence of the MMPs?
Yeah, well, this is something that we really need to look into further. The mechanism of the mechanism of vascular smooth muscle cell phenotypic switch. So the contractile cells that behave in a normal aorta, they become synthetic. So we have to look in cell culture, for example, at different pathways that may lead to this MMP production.
And so you think the MMP production is by the smooth muscle cells that became synthetic?
What we know is that the synthetic cells, they start to produce the MMPs, right? In the most of cases.
I also think a little bit about the elusive macrophages.
Macrophages
that
also, but because
was missing so badly.
But because they were missing in our data, we were really focused on the synthetic.
Though I hear a sound, so before the pedal comes, I would like to say that I'm very satisfied with your answer.
Thank you.
Mrs. Ganizada, as you hear and see, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis, and in particular the quality of your defense. And please await our results and our coming back here.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
be seated.
Mrs. Ganizada, the committee here present has assessed the quality of your thesis, and in particular the quality of your defense. And in view of its positive verdict, and taking into account the previous qualification that you have obtained, the committee had decided to grant you the degree of doctor. And Professor Bidar is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. I invite your supervisor now to take the floor.
All right.
Belooft u dat u altijd volgens de beginselen van wetenschappelijke integriteit te werk zult gaan, eerlijk, zorgvuldig, transparant, onafhankelijk en verantwoordelijk?
Ja, ik beloof het.
Krachtens de bevoegdheid ons door de wet toegekend volgens het besluit van de commissie hier tegenwoordig, verklaar ik u hierbij, Berta Hubertina Ganizada, tot dokter te bevorderen en u alle rechten te verlenen die daaraan volgens de wet en gewoonte zijn verbonden. Ten bewijze hiervan overhandig ik u nu de bul door rector, secretaris en overige leden van de promotiecommissie ondertekend en met het grootzegel van de universiteit bevestigd.
Please be seated.
Dr. Ganizada, ik mag jou als eerste feliciteren, ook namens je promotieteam, professor Leon Schurgers, Dr. Koen Racing, professor Jos Maassen, die kon er helaas door omstandigheden niet zijn. En ik feliciteer ook je familie, je vriend, je ouders, collega's, vrienden die hier aanwezig zijn. En ik wil graag ook de oppositieleden bedanken vandaag. Professor Koenen, professor Biesen, Dr. Heuts, and our colleagues from abroad, Professor Matic, all the way from Stockholm, Sweden, Dr. Gombert en professor Wenzel uit Rotterdam. Beste Berta, de oude Grieken hebben een gezegde. Een vos kent vele waarheden, maar een egel kent één grote waarheid. En daarmee konden ze op een mooie manier de mensen typeren tot vossen of egels. Een egel heeft met zijn 8000 stekels op zijn rug één overlevingsmechanisme, komt weinig in contact met veel dieren en leeft in zijn eigen wereldje. Daar waar de vos ontzettend veel dieren tegenkomt, heeft een scala aan overlevingsmechanismen. Wij als specialisten, medisch en aan de universiteitkant, zijn steeds meer egels. Wij verdiepen ons in ons eigen wereldje en wij gaan de diepte in en we worden van de buitenwereld bijna afgesloten. En daarvoor, om samen te kunnen werken, hebben wij vossen nodig. En zo'n belangrijke vos ben jij. Het is jou gelukt om afdeling hartchirurgie, biochemie en biomedische technologie op een fantastische wijze bij elkaar te brengen, wat heeft geresulteerd tot dat prachtig thesis. En daarvoor heb je een aantal kwaliteiten die heel belangrijk zijn. Je bent bijvoorbeeld altijd precies op tijd bij iedere vergadering, of een uurtje te laat misschien een keer. Maar je belangrijkste kwaliteit is volgens mij je doorzettingsvermogen. Een voorbeeld daarvan is bijvoorbeeld, je bent aangesteld op 1 februari 2020 en een maand later ging de universiteit op slot door de grote COVID-pandemie. Dus je kon je werk gewoon niet uitvoeren. En je hebt toch doorgezet, je kent je doelen, je laat je niet van de tafel slaan, je gaat ervoor en hier staan we dan 5 jaar later met een fantastisch verhaal. Dus heel goed gedaan. We zijn ontzettend trots op je. En dank voor alles wat je voor ons hebt betekend.
Dank u wel.
Ik geef het woord aan Robert.
Esteemed Dr. Ganizada, dear Berta, I am very happy to congratulate you with your doctorate, and I do that also on behalf of Maastricht University. And I would like to look back with you at this day, at your presentation and your thesis and your defense. With respect to your summary of your thesis, this was nicely illustrated and very clear. This is meant for people who are non-experts, and I hope that people here in the aula, but also the people of the live stream, understand what you have done in the last couple of years and which type of studies that you did and what kind of results you have obtained. And I'm quite sure that it is clear. You made it very clear. And I think it's important that scientists working at the university explain their work for a general public. You did it very well.
Thank you.
With respect to your thesis, it is, I think the committee will agree with me, of high quality, and you have studied really an important issue, and you have, I think, obtained very valuable results. And it has been characterized within the committee as bridge building work, which is a very good basis for future work. Your work was important, but it made a very good basis for further work, which may lead to really good results for patients. The committee, with respect to your defense, appreciated a lively discussion. And you had a very enthusiastic defense, so that sometimes we had to pace a little bit, just to make sure that everyone had the time to pose to you the right questions. So we were very happy with your defense, and you showed that you have a very broad overview and you are very aware of scientific development and scientific basis, and you have demonstrated to be a good and an excellent scientist. I congratulate not only you with that result, but also your 4 supervisors, of which three are here present. Professor Elham Bidar, and Professor Leon Schurgers, and Professor Koen Geesink. Congratulations with the results that we have seen today. I would like to include in my congratulations your family, your parents, your partner, and all members of your family. Congratulations with the results that you have seen today. I would like to thank both committees, not only this degree committee, but also the thesis assessment committee. Thank you very much for critically reading the manuscript. And in particular, I would like to thank the external members of the committee, just as Professor Bidar did already. Thank you very much for your efforts and your contributions to this, to critically reading and judging this manuscript. So Maastricht University is grateful to you. Before I close this academic ceremony, I would like to invite you for the reception. I think it's the best way to go to the rafter where it's cool. And it's much cooler than in the open air. So I would like to invite you after this ceremony to go to the rafter. In the meantime, this committee will take a picture with you, Berta, in the middle. Mm-hmm. And I would like to invite the close family to go with us, to share with us, and to go also to the hall where we will take a picture at the stairs, as committee and with you. Hereby, I close this academic ceremony.